Without further ado, today is indeed our pleasure to have Dr. Rajesh here with us today to share with us on the topic of new kid on the block for acid peptic disease. And we'll follow by a 15-minute Q&A session later. And Dr. Rajesh Kumar graduated as a medical doctor from the National University of Malaysia in 1999 and began his housemanship in Malacca General Hospital in 2004 and various hospitals under MOH. He also obtained his internal medicine from member of Royal College of Physicians in Glasgow and further pursued his specialty in gastroenterology in Eastern Health, Melbourne in 2009. Dr. Rajesh was the head of gastro unit in Klang General Hospital and also the head department in Serang Hospital. Besides that, Dr. Rajesh has also actively involved in clinical trials and published many scientific articles related to gastroenterology. Dr. Rajesh is currently practicing as a consultant gastroenterologist at Thomson Hospital, Kotak Damansara. So without further ado, let's welcome Dr. Rajesh. Over to you, Dr. Rajesh. Thank you.
Thank you. Thank you, Jermaine.
Yeah.
Right. Thank you, the organizing committee, for inviting me for this. Can I say Takeda Symposium? Will that be right to say that?
GP Symposium, yeah.
GP Symposium, okay. Takeda GP Symposium. To all my GP colleagues outside there, thank you. Thank you for coming. Thank you for spending time with us on this precious Saturday afternoon. Well, I guess you can't go out much, yeah. So can you guys hear me? I can hear a lot of interference. Yeah? Is that okay? My voice is clear, yeah.
Yep, I can hear you, Dr. Rajesh.
Okay, good. So yeah, GP colleagues, thank you for joining us. Now, the topic we're going to talk today is new kid on the block for acid peptic disease. For those who don't know me, I'm Rajesh. I work in Thomson Hospital, and I do visit University in Malaya as well. Now, who is this new kid on the block? Yeah, so that's what we're going to figure out today. I'm pretty sure some of you know what's the answer. Now, this is the outline of my talk. We're going to look at acid peptic disease and the current unmet needs in terms of treatment of these disorders. Number two, we're going to look at some case studies. Yeah. Number three, this is a new kid on the block. Potassium competitive acid blockers, in short, PCABs. You're going to see how they're going to suppress acid. We're going to look at some comparison with current PPI and see what is the difference between PCABs and PPI. And finally, is there evidence, is there clinical endpoint that's telling us that PCABs are better than conventional PPI? It's going to be an easy two-way session, guys. Yeah, feel free to pose in questions if you want to. All right, now let's take a quick recap about acid peptic disease. What do we know about acid peptic disease? Now, acid peptic disease is a spectrum. Yeah, one benign end is the group of disorders we call functional dyspepsia. It consists of postprandial distress syndrome and epigastric pain syndrome. After that comes this group of disorders called reflux diseases. Within reflux, you have erosive and non-erosive reflux disease. All right? And the next one is the spectrum of peptic ulcer disease. Within that, we have duodenal ulcers, gastric ulcers, erosions, and gastritis. And on top of that, the Helicobacter pylori eradication and GI prophylaxis for non-steroidals and aspirin also should be placed under the spectrum of acid peptic disorders. What happens if you do not treat these conditions? Number one, you can develop strictures. Number two, you have esophageal cancers. After that, bleeding, life-threatening bleeding. And if you're unlucky, it may perforate. And if you're even more unlucky, you'll end up having stomach cancers. So that's why it's important to treat these disorders. The first question that I have for you guys, the first clinical vignette. Oops, it wasn't me. Okay, now, what is true about proton pump inhibitors? Okay, what do you call that? Timothy, maybe we can start the polling. Yeah. A, PPI have a long half-life. All right. Okay, I can't see my screen. Yeah. Okay, PPI have a long half-life. And guys on the other end, if you have the answers already, you can start answering, yeah? So which is true about PPI? A, they have long half-life. B, they exert immediate acid suppression upon ingestion. C, it is a prodrug. D, PPI gives predictable acid suppression. And E, PPI can be taken irrespective of meal timing. So which is the right answer, you guys feel? Feel free to answer. There's no present here, yeah? It's okay if you get it wrong, you know? So I think we'll give about 5 seconds from here. Okay, I think we can wrap it up, Timothy. Yeah. Let's look at the results. Okay. All right. Okay. And do we know how many people answered based on this? 19 no answers. Okay. All right. Okay, fine. Maybe I should put the option there. Not so sure. Yeah. Anyway, some of them answered C. So that's the right answer. Yeah. Okay. So I'm going to close the polling and go back to the this one. Okay. Sorry. Okay. Sorry, I know this technology. I think we need to learn and unlearn. Yeah. Okay. Now, what is our current knowledge about treatment for acid peptic disease? The hero is PPI, right? PPI is the best for everything. It's better than antihistamines. It's better than H2 receptor antagonists. It's better than antacids. Yeah. So we know that PPI is the best treatment for acid peptic disorders. That's the current knowledge. Let's look at a bit of PPI pharmacology. It's a prodrug, yeah, just like what the question asked just now. Yes, it is a prodrug. It's metabolized by this enzyme called CYP450. Now, the problem is that many drugs use this pathway. So with that, PPI has a lot of drug-to-drug interaction. And the therapeutic effect of a PPI is not instantaneous, yeah. It takes 3 to 5 days after you ingest for you to get the maximum benefit. And on top of that, the bioavailability of PPI is very short. Its half-life is short. And not only that, one has to take it appropriate to the meals. It must be half an hour to 1 hour before the meals for PPI to exert its maximal pharmacological benefit. Let's look at the unmet needs in the management of acid peptic disease. Let's start off with reflux disease. Yeah? We know reflux is increasing. We also know a good 10% of those who have erosive reflux disease and a good 30% of them with non-erosive fail the PPI treatment. Why? Because of the nocturnal acid breakthrough. PPIs cannot give 24-hour acid suppression. So at night, about 2 to 3 a.m., you have acid being churned up into your esophagus. And we also know no matter what PPI dose and how long we give, Barrett's esophagus does not regress. And there's a small study that looked at all the patients who were given PPI in US. 173 of them, only about 20 to 30% of them had proper instructions from the doctor what time to take the PPI. So all this leads to poor outcome in terms of reflux management. What about peptic ulcer disease? We know that 10% of ulcers do not get better despite 12 weeks of PPI treatment. We know a good 30% of ulcers recur. Now, this is a very simple graph that shows us the benefit of keeping the stomach pH above 4, right? So if you look at on the left, the rate of healing esophagitis. On the bottom, the time where the pH is above 4. So the longer you keep the pH above 4, the better is the healing rate of the esophagitis. So what we know is that if the pH is above 4, esophagitis heals better. This is an example of how conventional PPIs do not keep the pH above 4 all the time. This is one of the popular drugs, as omeprazole. Yeah. So with this particular drug, when we give the patient, we realize that there are 2 spots when the pH goes below 4. All right. So these are the times where you do get some nocturnal acid breakthrough or even daytime breakthrough. In short, PPIs cannot completely block the acid secretion, so be it at night or day. So this causes heartburns to occur, even daytime or even nighttime. In short, the optimum pH for esophagitis healing must be more than 4. What about Helicobacter eradication? What are the problems that we face now, Helicobacter eradication? Well, if you follow the American College of Gastroenterology guidelines in 2017, there's a good 20% of failure rate in treating Helicobacter. If you fail to treat with first line, what do? You give second line. And what is the second line? One of it is bismuth-based quadruple therapy, BQT. And you know, the problem with this, because of the number of pills, the compliance is poor. And there's a study looking at 1,000 primary care doctors who started triple therapy. 30% of them didn't give the right directions for the patient to take. Now, this is an important slide for us to understand a little bit about Helicobacter pylori. All right, now we all know, so if you look at the blue chart, yeah, and the yellow chart, okay, this shows that Helicobacter can survive from a pH of 4 to the pH of 7. Okay, so this is the spectrum of pH by which Helicobacter can survive. But what's important is at what pH does it proliferate? So if you look at the chart in yellow, okay, pH 6 to 7, this is where Helicobacter is at its highest concentration. Why is it important? Because this is when the bacteria, amoxicillin and clarithromycin, can kill the bacteria. So what does this mean? It means that Helicobacter grows in a narrow pH 6 to 7, and it's sensitive to these antibiotics at 6 to 7. So for us to kill Helicobacter in an optimal fashion, we need to keep the pH above 5. That explains why PPIs don't do so well in terms of killing Helicobacter. They are good, but they're not the best at this point of time. Just a little bit about the physiology of acid secretion. Yeah? We know there are 3 receptors, histamine receptors, acetylcholine, and gastrin. When these receptors are activated, the proton pumps are activated, potassium is absorbed, and hydrochloric acid is secreted. Now, what does PPI do? It binds to this so-called activated, and I repeat, activated proton pump. So it prevents the formation of hydrochloric acid. But the problem is, the unstimulated or inactivated proton pumps are not blocked by the PPI. So what happens? After the PPI duration goes down, the unstimulated proton pumps become stimulated and they start secreting acid. Let's look at some clinical scenarios, guys. Yeah. Okay. Some questions. Okay. Just to ease you guys a little bit, get into the mood a little bit. Yeah. Okay. Case 1. Miss YKL, 37-year-old obese female, presented with central chest burning discomfort and nocturnal symptoms. Sounds like reflux, but you've got to exclude coronary artery disease as well. Now, she also says that the symptoms are aggravated by food and is relieved by antacid. And she's got no alarm symptoms. ECG is normal. So unlikely coronary artery. Most probably reflux disease. So what's your next best action? Timothy, we can start polling, I think. First, are you going to ask her to do some therapeutic lifestyle changes? Lose weight, exercise? Or are you going to ask her to continue taking the antacid? You're going to start her some PPI? Or you think endoscopy is the best way to go? Or should we start some H2 receptor antagonists? You all can start answering. We'll stop in about 5 to 10 seconds. Okay. I think we can wrap it up. Not bad. 20 out of 31. Oh, no answer. Oh, okay. So 11 answering. All right. Now, some say therapeutic lifestyle is the way to go. Some say start PPI. Some say OGD as well. The right answer would be to start PPI. Okay? Now, get this right. Give me a second. Okay. The current guidelines are very clear. If you have somebody at her age with no alarm symptoms, test and treat is the way to go. So PPI would be the way to go. You don't need endoscopy at this point of time. Now, after starting PPI for 6 weeks, we realized that her symptoms did improve, but her nocturnal acid symptoms are persistent. So what is the next best option for you here? You can start polling. In short, symptoms are not really improving with standard PPI dose. So either you give antacid on night, or you raise the pillow to 45 degrees, or do you increase the proton pump inhibitor to twice a day, or you start vonoprazan 20 or vonoprazan 10. Okay, let's wrap it up. Okay, most answered vonoprazan 20. Yeah, okay, good, good. Okay, it's not because Takida is sponsoring the talk, but I guess here you can have two answers which are almost right. Okay, now one of it will be, give me a second, I need to come out of this. Okay, one of it will be, what do you call that? Of course, start vonoprazan 20 milligram. You want something with better acid suppression, and 20 is better than 10 in terms of healing at this point of time. But pantoprazole 40 twice a day is not that bad an option, but we know it's still inferior to vonoprazan 20. You'll see evidence as we go. Now, next question. 39-year-old male presented with persistent dyspepsia, no alarm symptoms, UBT was positive. So standard male going to your clinic, no alarm symptoms, UBT positive. What do you do for him? Let's start polling. Do you give PPI? Do you just give celecoxib because of the pain? Or do you start clarithromycin-based triple therapy, or bismuth-based quadruple therapy, or would you start metronidazole-based triple therapy? What's the best choice for him? Okay, let's wrap it up. Clarithromycin, yes, that's right. Majority answered that. Some said PPI alone. Well, if the UBT is positive, then what you should do is probably start him on triple therapy. And in Malaysia, at this point of time, the evidence is with clarithromycin-based triple therapy. Now, the problem is, what do you call that? If you fail the triple therapy, like him, he can't complete the dose. He repeated the UBT in 3 months. It's persistently positive. What's your next best plan of action? Let's start answer. Do you do a culture? For that, you need to do endoscopy. Do you repeat the same regime? Some of them still do. Or do you change to levofloxacin-based triple therapy? Or would you want to change to bismuth-based quadruple therapy? Or would you want to use vonoprazan with metronidazole and amoxicillin? Remember, yeah, he has a lot of side effects. He can't tolerate a lot of pills. So what would you choose? Okay, let's wrap it up. Okay, yep. Majority answered Vosinti. Some answered levofloxacin. Okay. So I guess the right answer here, in my opinion, okay, will be 2 as well. Okay, either Vosinti-based treatment, or you can consider levofloxacin. But if you look at newer studies, people want to eradicate this bug. So you want to try something stronger, like Vosinti, because it definitely gives you better results. All right. Now let's move on. Okay. Now I'm halfway through my slides. Okay, now I'm pretty sure many of you know who this person is. If you can see him touching his tummy here, it's not because that he likes the pose. That's because he had peptic ulcer disease as well. Well, that's Napoleon Bonaparte, yeah? All right, he died of stomach cancer eventually. Let's look at some PCAPs. Now, from here on, we'll be looking at some studies, yeah? Now, PCAPs, or potassium competitive acid blockers, it was invented 30 years ago. The main problem with PCAPs was hepatotoxicity. Now, in 2015, they have created vonoprazan fumarate, which is out in the market. There's a lot of studies. There's one more PCAB called tegoprazan is undergoing clinical studies in South Korea. So there are two PCABs in the market at this point of time. What's so special about vonoprazan? Number one, its chemical structure is different from other PCABs. Number two, it's got high pKa. That means it concentrates highly on the parietal cells. It's rapidly absorbed and reaches maximal level within 2 hours. That's fast, yeah? And the half-life, this is the best part, 7 hours, unlike the conventional PPI, which is 2 hours. And it doesn't use the conventional metabolic pathway in the liver. So drug interaction is lower. Now, how does vonoprazan act? Now, this is a simple diagram illustration to show how it works. This is the parietal cell, the blue triangular structures that come, that's vonoprazan, and the purple circular structure that you see, that's the proton pump. The proton pump, the one that is flat is inactivated, the round one is activated. So the good thing about vonoprazan is it inhibits all the inactivated pumps as well as the activated pumps, thus giving it an advantage over the standard PPI. This is a computer-stimulated model looking at the concentration of PCAB as opposed to PPI. So if you look at the top graph, upon ingestion, straight away the level of the PCAB reaches the therapeutic target, and then it is sustained with subsequent dosing. As opposed to PPI, you have to take 3 to 4 doses to reach the therapeutic benefit. So in short, PCABs achieve full effect from the first dose, and it provides similar level of inhibition with repeated dosing. Now, this is a simple study looking at the pharmacokinetics of vonoprazan with a single dose in terms of meal timing. So this study was done by taking a single 20 milligram in two conditions. One, the light blue one, while patient was fasting. The other one, postprandially, as in after meal. So it was noticed that the level of vonoprazan, whether before meal or after meal, in the blood is the same. So what does this mean? It gives us the ability to time it irrespective of meals. Hence, it gives you the dosing flexibility. Let's look at PCABs versus PPI. This is a randomized open label crossover study. Okay, it's a simple study that looked at how well vonoprazan versus esomeprazole is in 20 healthy Japanese males in terms of keeping the pH above 4. We know why now, right? We need to keep the pH above 4. So in this single, on day one dosing, if you realize the light blue, the blue line is vonoprazan, the gray one is esomeprazole. So with a single dosing, vonoprazan managed to reach therapeutic level and it was sustained above pH 4. Unlike esomeprazole, it hasn't reached the therapeutic level yet. This is dosing on day 1. What about dosing on day 7? Vonoprazan remains above pH 4 as opposed to esomeprazole. It starts to escalate after 7 days. So in short, vonoprazan 20 milligram gives greater acid suppression, increases gastric pH as early as 2 hours after administration, faster onset of action, and the therapeutic dose occurs immediately after the first administration. Now, we're going to our last chapter. We're going to look at some evidence that's going to support all these claims. Let's look at some clinical endpoints, yeah? So just bear with me, more dry slides, okay, but important. For example, the evidence in GERD. What evidence do we have in reflux disease? It's a very simple study. It's a randomized clinical trial that looks at vonoprazan versus lansoprazole in symptom relief. So we are looking at symptom relief first here. In those who have confirmed erosive esophagitis, numbers were not big, just 32 of them. All right, so here on the left is the percentage of patients who had symptom relief. In the bottom, number of days on treatment. The one in red is vonoprazan outcome. The dotted lines is lansoprazole outcome. So what we can see here is that even in day 1 of taking vonoprazan, we have a good 31% of them in this group who had complete relief of symptoms, as opposed to only 12.5% in the lansoprazole group. So that is a statistically significant difference in terms of symptom relief even in day 1. All right. As the days went by, the gap became bigger in terms of patients who had better outcome with vonoprazan compared to lansoprazole. The other thing that they found is there was complete nocturnal heartburn relief in the vonoprazan group as opposed to the lansoprazole group. So when you can tackle your nocturnal acid breakthrough, then most probably you will succeed in giving good esophagitis symptom relief. Here, another study that looked at endoscopic evidence of healing of erosive esophagitis. Just now was symptoms, right? Now, endoscopic healing. So this is a randomized control study, but it's a non-inferiority study. They compared vonoprazan and lansoprazole, okay? But they took about 400 patients, divided them into two groups, So those who've been confirmed to have erosive esophagitis, so they gave vonoprazan 20 in the blue bar, and a gray bar is lansoprazole. They continued at week 2, week 4, week 8 with endoscopies done at all these weeks. So if you look at week 8, vonoprazan is not inferior to lansoprazole in terms of healing of the erosive esophagitis. An important aspect of this study is they continued these patients for a good 52 weeks to look at the safety of vonoprazan. And vonoprazan was shown to be well tolerated and safe for 1 year period. Okay, all of us must be questioning, right? Is it safe to give this drug? Yes, for 1 year, seems okay so far. Now, this is the last slide for erosive esophagitis. This looks at what is the difference in terms of vonoprazan for patients with mild esophagitis as opposed to severe esophagitis. Is there a difference or not? Okay, so this study shows that in those who have mild esophagitis, there's no much of difference between vonoprazan and lansoprazole. The outcome is about the same. But in severe esophagitis, it shows that those who were on lansoprazole, the rate of recurrence was higher compared to those on vonoprazan. But what you need to remember is between 10 and 20 vonoprazan, for maintenance purposes, there's no difference. Alright, so in essence, vonoprazan is not inferior to lansoprazole for mild reflux when it comes to maintenance, but it's definitely better than lansoprazole in severe reflux disease. Let's look at some evidence in terms of Helicobacter pylori eradication. Is vonoprazan better or is it not? Now, this is a summary of all the studies looking at the efficacy of vonoprazan versus PPI-based treatment for first-line therapy. All right? Okay? So if you look at these studies here, right? So the one in pink is the vonoprazan group. The one in purple is the PPI group. Let me highlight this to you. What they've done is they have divided into clarithromycin sensitive group and clarithromycin resistant group. Okay, here is all the outcomes for clarithromycin sensitive group. Yeah. So if you look at the outcome, vonoprazan and PPI group is about the same. No difference. 100% here, 88. Although numerically vonoprazan seems to be better, but statistically not much of a difference. But if I were to show you the resistant group, now there's a significant difference. Vonoprazan eradication rate 82%, whereas PPI group is only 40. If I were to show you NODA study, vonoprazan was 87% and PPI group was hardly 50%. If I were to show you Matsumoto study, vonoprazan had close to 80 and PPI was only 40. So what it means is that when it comes to treating patients with clarithromycin resistant cohort, vonoprazan does better. What about, so that was vonoprazan as first line. What about vonoprazan as second line therapy? There's this systemic review. This is what we call a forest plot. Yeah. Now don't be too frazzled by this. What's important is just look at the diamond. Where does the diamond fall? The diamond falls favoring vonoprazan group in terms of outcome for second line therapy. So it's clear when it comes to second line therapy, vonoprazan is definitely better than the PPI group. Now, the last bit of evidence in terms of peptic ulcer disease. Is there any evidence to suggest that vonoprazan is better in peptic ulcer disease? Well, I have to say the evidence is scanty. but this is one study that looked at about 400 patients in terms of gastric ulcer and duodenal ulcer healing. What it showed here was that vonoprazan was tolerable with regards to lansoprazole, but it is not inferior to gastric ulcer healing. It's got similar efficacy for duodenal ulcer healing, but it's just one study, yeah. So we need to have more evidence moving forward with regards to peptic ulcer disease. What about the safety and efficacy for GI prophylaxis? Let's say you have a patient on non-steroidal, would you? There's this study, only one study, there are just very few scanty studies. It's pretty big though, it had 600 over patients that looked at 24 weeks followed by 104 weeks. What they found was vonoprazan was not inferior to lansoprazole in reducing the recurrence of ulcers. Okay, so as I said, vonoprazan was not inferior to lansoprazole in the prevention of NSAID-induced peptic ulcers, and it's well tolerated for up to a year. So here again, we have evidence that you can give vonoprazan for a year, and it's not inferior to lansoprazole in terms of efficacy. What we need to do in moving forward, we need superiority studies. Yeah. Now, this is almost a summary of what we need to know about vonoprazan. The dosage and indication. For erosive esophagitis, we start off with 20 milligram, then we maintain with 10 milligram. There's enough studies to show that you can give it for a year. And in eradication of Helicobacter pylori, we use it 20 milligram BD for a week. Now, evidence in erosive esophagitis and eradication of Helicobacter is pretty strong. What about gastric ulcer, duodenal ulcer, and GI prophylaxis? Evidence is still patchy. We need to wait for more studies. And when it comes to functional dyspepsia and upper GI bleed, so far there's no evidence. We need to practice some caution, especially with vonoprazan. Hepatotoxicity, so far there's nothing been documented, but we know in the beginning a lot of PCAPs were associated with hepatotoxicity, so we need to be careful with those who have renal impairment and liver impairment. There's some reported cases of hypergastrinemia, but once you stop the treatment, the gastrin level goes down. Long-term safety of vonoprazan is still of question. We know 1 year data is safe, but what about longer than that? So we need to wait for more studies to come. My last question. What is true about vonoprazan? Timothy, we can throw in the polls. It has a short half-life, 2 hours. It's got delayed onset of action, 6 hours. Dosing is independent of meal timing. Cannot be used for Helicobacter eradication. And lastly, it's got strong evidence in the use for patients with non-erosive reflux disease. Okay, we can wrap it up. All right, so majority answered dosing independent of meal timing, which is correct, yeah? Okay, so I think the message went across. Now, so conclusion, ladies and gentlemen, PPI has been the mainstay of treatment for acid peptic disease for past 20 years, yeah? Now, despite that, there's still significant unmet needs and limitations. PCAPs are the newer acid suppressing agents. They seem to be better. They seem to act longer, and they're predictable in terms of acid suppression. Evidence for PCAPs use is strong in erosive reflux disease and Helicobacter eradication. Other diseases, we have to wait for more evidence, especially like GI prophylaxis and peptic ulcer disease. Now, there's some shortfalls that one can see clearly in the studies with regards to PCAPs. Most of them are non-inferiority studies. There's no local data. Most of them come from Japan. Study population is not heterogeneous, yeah. And the PPI comparator uses a lower dose. And you realize the HP eradication regime is a bit different, yeah. They use 400 milligram clarithromycin, 750 amoxicillin, which we don't use it in our country. So this is my last slide. Thank you very much, ladies and gentlemen, for your attention. PCAPs versus PPI. I hope it's not like the Republicans versus the Democrats. All right. Thanks so much. We're open for questions. Yeah.
Yeah, thank you so much, Dr. Rajesh, for your sharing so that now we can see from a different perspective about acid peptic disease. Yep. So now we'll open up for Q&A session. If you have any question for Dr. Rajesh, feel free to unmute yourself to ask, or you can comment, post your question in the chat box below. Yeah. Let me check the chat, yeah. All right, there's one question here. Is H. pylori eradication takes 7 days or 14 days?
Good question. Okay, which regime are we talking about? So if we are talking about the standard clarithromycin-based regime or levofloxacin-based regime, or even the standard regimes, we give 14 days, 1-4. If we give bismuth-based quadruple regime, it can be anywhere between 10 to 14 days. If vonoprazan-based regime, now in Japan, they use it for a week. In Malaysia, we're still not sure. Professor Goh's team has been using it for 2 weeks. So yeah, that's the answer for the duration of treatment for Helicobacter pylori eradication. Standard treatment so far that we have is 14 days.
Okay, thank you, doctor. Any more questions? You all can unmute yourself and ask.
Yes, this is the problem with online, isn't it? Don't get the people to see their reaction and whatnot.
But I do see more questions in the chat box now.
Okay,
so what's the long-term side effect on vonoprazan?
Oh. Yeah, I wish I knew the answer. I guess with whatever evidence that we have at hand now, so far the time frame that they've looked at is a year. There's another study in reflux disease that looked at 104 weeks, 2 years. There were no major side effects. There was one patient who had a subarachnoid bleed, which they believe is not related to the drug. So I believe in the long run, the side effects of vonoprazan is going to be the same as any acid suppressing agent. So like standard PPI, you have the claim. I use the word claim. Claim side effects of calcium deficiency, B12 deficiency, analgesic nephropathy, Clostridium difficile infection. It's basically all side effects related to prolonged acid suppression. That's going to be the side effects of vonoprazan moving forward, though. There's been some mice studies that shows that very high doses of vonoprazan used for a very long period of time is associated with neuroendocrine tumors. But this is in mice, and they use very high doses. So in humans, 2-year study, nothing much. Yeah. But it will be similar to other forms of acid suppressing agents, I believe.
All right. Another question from Dr. Nada, is vonoprazan available now and cost? For this question, probably it is available now. It's actually launched last year in August. It's available in private hospital and also GP. For the cost, probably I will jot down your contact number. Probably I will get the rep in charge to contact with you later on. Yeah.
Hi, Dr. Nada. Hi, how are you? Good to see you here. Yeah, that's a confidential question. Takida only gives the answer. So yeah, they will let you know probably. But yeah, it's readily available. Yeah, it's been with us for I think more than a year. Yeah, about that.
Yeah, more than a year since last year August.
Last year, yeah.
Yep. Yeah, thank you. Another question. Why is Vosinti not approved by FDA? Is there any reason?
The reason is simple. You haven't had enough studies in Caucasian groups. The studies are only in Japan. Okay, so it's not that it's not approved because it's not good or it's dangerous. But for FDA to approve, you need to do studies on their soil. If you realize even dimicron MR is not approved by FDA, so that doesn't mean it's not safe. Yeah? So I think you have to give it some time for them to do more studies in Caucasians and throughout the world for it to be approved by FDA. FDA is an American body, so you have to do your studies in America.
Yep. All right. Any new question? Any more question from the floor? Welcome, Dr. Ho. All right. So far, there's no more question in the chat. If there's no further question, probably we'll wrap up this event. So before we actually end the session, I would like to request all of you to turn on the camera if your PC comes with a webcam or you have a camera in your tablet, so that we can take a group photo together. Just a quick,
interesting.
yeah, just a quick one.
Never heard of that before. You see, Jermaine, next time what you do, right? If you happen to do it during office hours, give them a lunch pack. Send a lunch pack to their place,
Okay.
which won't be wrong actually.
Yeah, I'll take note on that. All right. Yeah, thank you for doctor who actually turned on their camera. Thank you so much. It's a lovely Saturday, and thank you for spending your time with us today. That's it. I will end the session here.
Picture taken?
Yep.
Oh,
I
okay,
will leave
great.
it. It's already taken.
All right.
Yeah.
All right. Thanks, everyone. Bye.
Thanks.
Have a good day.
Thank you. Yeah. Have a great weekend.
Bye.
Thank you.
Bye.
Thank you, Dr. Rajesh.
All right. Okay. Welcome.
Thank you.
Thank you, Dr. Rajesh. Bye.
Cheryl. Let Lee. Bye.
Bye. See you around.
Yeah.